Welcome to the Deep Dive. Today, we're diving into one of the most fundamental and, frankly, fascinating questions in all of medicine and public health. It's the question that sort of underpins nearly everything we believe about health. How do we really know if a new medicine works? Or if, a particular diet truly prevents disease? It's easy to hear a friend's story or maybe a captivating news headline, but what's the actual scientific bedrock beneath those claims? How is genuine medical knowledge truly established, beyond just, anecdotes or gut feelings?
That's exactly where we plunge into the world of epidemiology. And, forget the hazmat suits for a moment. While tracking pandemics is certainly a critical application, at its core, epidemiology is the science of uncovering patterns in health and disease across entire populations. It's really about asking who's getting sick, where are they getting sick, when, and crucially, why, and then using those answers to protect us all. It's the basic science that underpins virtually every public health decision and clinical guideline you encounter. It's the critical lens through which we generate real, actionable evidence about health and disease, moving far beyond mere observation or individual stories.
Right. So our mission for this deep dive is to unpack the various epidemiological study designs, the different ways scientists investigate these really crucial questions. We're going to try and transform what might seem like incredibly complex research methodologies into clear, digestible insights. Get ready for some serious aha moments, I think, about how the very fabric of health knowledge is woven, all drawn directly from the fascinating source material we've gathered for you. Let's get started.
Okay, let's unpack this word, epidemiology. It sounds like a very serious, almost intimidating word sometimes. What does it truly mean for us beyond those, dramatic pandemic headlines?
Yeah, it's much broader than just pandemics, though that's certainly a key part of its application. At its heart, epidemiology is defined as the study of the frequency, distribution, and determinants of diseases, or really any health-related events, states, and processes within specified populations. And crucially, it's also about applying this knowledge to control health problems. Its roots are actually truly ancient. You have thinkers like Hippocrates around 400 BC already linking human diseases to environmental factors, like he did in his work on airs, waters, and places. But as a structured modern science, it really expanded significantly after 1940, evolving into the rigorous field we know today.
So it's not just about one person getting sick. It's more seeing the bigger picture, how illnesses move through entire communities and populations. That shift from an individual focus to understanding population patterns seems absolutely key.
Exactly. While clinical medicine focuses on diagnosing and treating disease in individual patients, epidemiology provides the basic and essential science for understanding human health and disease at a population level. It forms the very foundation for medical research methodology, helping us identify underlying causes, what we call risk factors, and generating crucial data that's indispensable for planning and evaluating health services. Without understanding these broader patterns, it's much harder to intervene effectively or prevent disease on a wide scale. It's the science that allows us to move from treating one patient to protecting an entire community. Okay, so building on that, epidemiological studies are broadly categorized into two main types. This classification really helps us understand the fundamental approach a researcher takes when trying to answer a health question. First, you have observational studies. In these, the investigator simply observes. They don't interfere or manipulate any variables. They're essentially watching what naturally unfolds in the world.
So kind of like being a quiet detective, just gathering clues from what's already happening. You're not changing anything in the scene, just carefully documenting it.
That's a great way to put it, yeah. And within observational studies, there are two subdivisions. There are descriptive studies, which, as the name suggests, describe the occurrence and distribution of disease by factors like time, place, and person. These are vital for generating initial hypotheses and spotting trends. Think of things like case reports that detail an unusual patient presentation, or simple surveys that give you a snapshot of a health condition in a community. Then you have analytical studies, which go a step further. They investigate predefined hypotheses about cause-effect relationships by comparing groups still without intervention, just observing and analyzing differences between them.
Okay, and what about the other major category? The one where researchers do get involved, actively change something.
Right. That brings us to experimental or interventional studies. Here, the investigator actively intervenes or manipulates a variable. Instead of just observing, they're actively changing something, maybe giving a new drug or implementing a new public health program to see what happens. These designs are generally considered the strongest in establishing causation. They give us the highest level of confidence that one thing truly causes another. They allow us to move beyond just seeing a correlation to finding direct evidence.
Okay, so observational studies are like being a detective, gathering clues from what's already happening naturally. You're observing the scene as it is. But experimental studies are more like setting up a controlled lab test, right? To see what happens when you change something, like adding a specific chemical or introducing a new variable. You're manipulating the environment to understand that direct cause and effect. That analogy really clarifies the distinction.
That's a really good analogy, yeah. It captures the difference between watching and actively testing.
So our sources bring up a common, really critical question that perfectly illustrates the power of these study designs. Let's imagine a pharmaceutical company has a new drug, we'll call it drug X, for type 2 diabetes. They think it's better than what's already out there. How do we rigorously prove it's genuinely better rather than just, relying on hopeful anecdotes or some promising early signs? What's the absolute gold standard for getting that answer?
Well, what's fascinating here is that to answer that question with the highest degree of scientific certainty, the ideal and most scientifically robust study design is an experimental design. Specifically, a randomized controlled trial, or RCT. RCTs are unequivocally considered the gold standard for evaluating the efficacy of a new therapeutic or preventive procedure in clinical practice. They provide the best evidence of causal association because of their rigorous control over confounding factors, both the ones we know about and the ones we don't, through that really powerful tool of randomization. It's the go-to method when you need to be absolutely confident that the drug, and not something else, is causing the observed effect.
This sounds like an incredibly meticulous process. Let's walk through the steps. Let's imagine the journey of this drug X from a lab to potentially helping countless patients. Where do we even begin with something that sounds so monumental?
It truly is meticulous, yeah, and every single step is critical for a valid and ethical study. First, before anything else, you must decide if a clinical trial is truly required. And this isn't a trivial step. You need an exhaustive review of existing literature, including meta-analyses of both published and unpublished papers, to make sure the research question hasn't already been answered definitively. There's really no point in putting people through a trial if the answer is already out there. And beyond that, it's crucial to carefully assess the ethical implications. No human should be exposed to hazardous interventions, nor should they be denied an effective existing treatment just for research purposes. It's about finding that balance between advancing knowledge and protecting the participants.
Right, so it's about making sure you're not just reinventing the wheel, and critically, that you're operating within strict ethical boundaries. Okay, once those hurdles are cleared, what's next?
The next crucial step is to clearly state the research question and variables of study. And this question needs to be incredibly precise, developed after thorough reading and, discussions with experts. If you have multiple questions, you'll define a primary question, which guides your sample size calculation and statistical analysis, and then any secondary questions. You also need to clearly list all the variables. The exposure variable, so drug X versus the standard treatment or maybe a placebo. The outcome variable, the specific health event you're measuring, like control of type 2 diabetes, with clearly defined primary and secondary endpoints. Any co-interventions, other treatments subjects might get, and all potential confounding variables, those factors that could distort the relationship between the drug and the outcome, things like age, sex, other health conditions, or lifestyle factors. Defining these up front is like drawing a very detailed map for your research journey.
Wow, that seems like a lot to define right at the start. What about the people who will actually participate in this trial? How do you decide who's in and who's out?
That leads perfectly to the third step. Enumerate inclusion and exclusion criteria. You have to precisely define the characteristics of patients eligible for the trial, your inclusion criteria, based on their demographic and clinical features. For example, specific age ranges, certain diagnostic thresholds for diabetes, maybe the absence of other severe conditions. Equally important are the exclusion criteria, defining who won't be included. Now, while having more exclusion criteria can lead to more precise findings by making your groups more similar, you have to remember this can also limit the generalizability of your results to broader, more diverse populations. It's a fundamental trade-off in research design.
Yeah, I can see that trade-off. It sounds like you're trying to find a balance between getting very precise results and making sure those results are actually relevant to real-world patients who might not fit such narrow criteria.
That's precisely the challenge. Next, you define the study populations. We usually distinguish between the reference population, sometimes called the target population or universe. This is the broad group of patients to whom the trial's findings are expected to apply, for instance, all adults with type 2 diabetes. Then there's the actual study population, which is a well-defined subset of that reference population from which your study sample is actually drawn. This is often chosen for administrative convenience, maybe all type 2 diabetic patients at a specific set of hospitals, but it should be reasonably representative of that larger target population if possible.
Okay. And once you have your populations defined, how do you know how many people you actually need for the study? I mean, why can't researchers just guess the number of participants they think would be enough? Seems simpler.
But that brings us to a really critical step. Calculate the sample size. This is definitely not guesswork. It's a rigorous statistical calculation essential for ensuring adequate statistical power and, importantly, ethical conduct. You need to specify several parameters beforehand, like the probability of a false positive result, type I error or alpha, typically set at 5%, or the study's ability to detect a true difference if one exists, power or 1 beta, usually set at 80% or more. You also need the expected outcome proportion in the control group, often based on previous studies, and crucially, the effect size, which is the minimum clinically significant difference the study aims to detect between the groups. The ethical imperative here is really strong. Use enough participants to get meaningful results and detect a real effect if it's there, but not too many, which would be wasteful of resources and expose more people than necessary to potential risks from an unproven intervention.
That makes perfect sense. You want to be efficient and responsible with resources and, most importantly, with people's health and time. So once you know how many people and who they are, how do you make sure the study runs smoothly and consistently for everyone involved?
That's the 6th step. Develop detailed protocols and instruments. This means creating meticulous, step-by-step protocols for absolutely all clinical procedures, laboratory investigations, questionnaires, interview methods, everything. These must be standardized and validated to ensure consistency across all participants and investigators, no matter where or when the data is collected. Any questionnaires or instruments used must be developed scientifically and, really importantly, pre-tested, usually through a pilot study, to ensure they're clear, understandable, and effective at capturing the necessary information accurately. Consistency is absolutely key here for valid results. Following that, you move to enrolling participants. This involves making a comprehensive list of all eligible individuals based on your inclusion and exclusion criteria, and then recruiting them into the study. A paramount part of this step is obtaining informed consent from every single participant. This isn't just a signature on a form. It means ensuring they are fully aware of the study scope, its potential risks, its expected benefits, and crucially, that their agreement to participate is entirely voluntary, completely free from any coercion or pressure. It's about empowering the individual to make a truly autonomous decision about their health journey within the trial.
Okay, now here's where it gets really interesting, right? The part that truly sets RCTs apart from other studies. This is the core magic, the sort of scientific superpower of an RCT, isn't it?
Absolutely. This is randomization, or random allocation, and it truly is the heart of an RCT. It involves randomly allocating those eligible participants into your 2 groups, the intervention group, getting drug X, and the control group, getting the placebo or standard treatment. The brilliance of randomization is that it ensures these groups become absolutely similar in all respects right at the start of the study, before any intervention. This means both known and, importantly, unknown confounding factors, those hidden variables that could influence the outcome, are distributed equally between the groups purely by chance. Because of this, any difference you observe in the outcome between the 2 groups at the end can then be safely attributed to the intervention, the drug itself, rather than some other inherent difference between the groups that you didn't account for. Simple methods like random number tables, coin tossing, or specialized computer software are used to achieve this truly unbiased allocation. So once the groups are randomized, the 9th step is to introduce the intervention and placebo control modalities. The intervention group receives drug X, while the control group receives an inert substance, the placebo, which is meticulously designed to be identical in appearance, taste, everything, to drug X, or they receive the existing standard treatment if that's the more ethical comparison. It's vital to ensure compliance here. So clear instructions on dosage, administration, frequency are provided, and procedures are in place to check compliance, like maybe pill counts or testing for drug metabolites in urine. Consistency in how the intervention is delivered is just as important as consistency in selecting participants. Step 10, which we'll circle back to, is to ensure blinding. This is closely related to randomization in its ability to prevent bias.
Okay, saving that one for a moment. What happens after the drug or placebo is given?
Right. The 11th step is follow-up and assessment. Participants must be meticulously followed until the trial's predetermined endpoint. The ascertainment of outcomes, meaning how you determine if the disease is controlled or not, must be done very carefully, ensuring validity and reliability in your measurements. It's also incredibly critical to minimize loss to follow-up or attrition where subjects drop out of the study before it ends. A high rate, say over 30%, and particularly if that loss is differential, meaning more people drop out from one group than the other, or for reasons related to the treatment or outcome, can seriously bias results and really erode confidence in your findings. Researchers need robust strategies for retrieving these individuals or carefully accounting for them in the analysis. Furthermore, predetermined stoppage rules should be in place. These allow the trial to be terminated prematurely if there's clear evidence of overwhelming benefit or significant harm from the intervention. These rules are crucial for both ethical conduct and scientific integrity.
And finally, after all that meticulous work, all those carefully collected data points come together for the numbers, the analysis part.
That's the 12th and final step, statistical analysis. You typically start by presenting a participant recruitment and flow chart showing exactly how many people were screened, how many were randomized, who received the intervention, who completed the study, and who dropped out. Then you provide a table showing baseline comparisons between your intervention and placebo groups to confirm that randomization was indeed effective and the groups were similar on key characteristics at the start. You then construct that classic 2x2 table to summarize your main outcome data, drug X versus placebo, outcome versus no outcome. From this, you'll calculate the incidence in exposed, i.e. the rate of the outcome in the drug X group, and incidence in non-exposed, i.e. the rate in the placebo control group. From this, you calculate the relative risk, RR, which is simply IE divided by INE. For drug X, if it works better than placebo, you'd expect an RR less than 1, indicating protection or a reduced risk of the negative outcome. You also calculate the numbers needed to treat, NNT, which is 1 divided by the absolute difference between INE and IE. IE. This is an incredibly practical measure for clinicians. It tells them how many patients need to be treated with drug X for one additional person to experience the beneficial outcome compared to the control group. Finally, you perform statistical tests like the chi-square test or a t-test to assess whether your findings are statistically significant, unlikely to be due to chance, and you decide on your analysis approach. Often, intention to treat analysis is preferred, where subjects are analyzed based on the group they were originally randomized to, even if they didn't fully adhere to the treatment protocol. This often gives a more realistic estimate of the treatment's effect in the real world.
Okay, let's circle back to step 10. You mentioned blinding a few times, and it sounds incredibly crucial working alongside randomization. Can you explain what it is and why it's so vital in preventing skewed results?
This raises a really important question, and yes, blinding truly is a cornerstone of robust experimental design, working hand in hand with randomization to minimize bias. Blinding is essentially a technique used in experimental studies, especially RCTs, to minimize bias by ensuring that individuals involved in the study are unaware of who is receiving the intervention versus who is receiving the control, that is, the placebo or standard treatment. Its fundamental purpose is to ensure that the assessment of the outcome is as objective and unbiased as possible. It prevents expectations, conscious or unconscious, from influencing the data collection or interpretation.
So it's all about maintaining objectivity, right? Preventing anyone's expectations or preconceptions from clouding what the actual results are showing. How does that play out in practice? What kinds of bias does it prevent?
Precisely. Let's break down why it's so important. First, it prevents subject bias, which is often called the placebo effect or sometimes respondent's bias. If participants know they are receiving a new or experimental drug, they might perceive or report feeling better, even if the drug has no real biological effect simply due to their belief or hope in the treatment. Conversely, those who know they're on a placebo might feel deprived or less hopeful and perhaps report worse outcomes or fewer improvements. Single blinding, where only the subject is unaware of their treatment assignment, addresses this specific bias by equalizing those expectations across the groups. Second, blinding prevents observers' or investigators' bias. If the investigator, the person administering the treatment, interacting with the patient, or assessing the outcome, knows which group a patient is in, they might consciously or subconsciously treat patients differently. They might, for example, probe more deeply for specific symptoms or side effects in the intervention group, or perhaps less diligently in the control group. They might even interpret ambiguous symptoms or results in a way that favors their hypothesis about the treatment. This can lead to a differential assessment of the outcome, skewing the results. Double blinding, where neither the subjects nor the investigators' assessors are aware of group assignments, is considered the gold standard for this reason. It protects against these often subtle, unconscious influences from both sides. And third, in its highest form, blinding prevents analyzers' bias. In triple blinding, even the person analyzing the data is unaware of the group assignments until the primary analysis is complete. This prevents any conscious or unconscious manipulation of statistical analysis, data dredging, or selective interpretation to favor one group over the other. It adds yet another layer of scientific integrity to the process.
Okay, so if a study is single-blind, it means only the participant doesn't know their treatment. Double-blind means both the participant and the person giving the treatment or assessing outcomes don't know, and a triple-blind means all of them, plus the data analyst, are kept in the dark. That makes sense.
That's right. Those are the common levels. And for blinding to be effective, especially in drug trials, the inert placebo must be absolutely identical in shape, color, size, and taste to the active intervention. Every effort is made to make them completely indistinguishable. However, it's important to acknowledge that blinding can be difficult, sometimes even impossible in certain types of trials. For instance, in surgical trials, it's pretty hard to blind the surgeon or the patient to the fact that surgery has or hasn't occurred. In such cases, researchers make efforts to make the outcome criteria as objective as possible, things like lab values or survival rates, and often bring in independent evaluators who are blinded to the intervention group to assess those outcomes, mitigating the unblinded elements as much as possible. Okay, so now let's try to summarize the key advantages and disadvantages of this powerful experimental design, the RCT. The advantages are truly significant, which is why it's held up as the gold standard. RCTs are considered scientifically ideal and provide the most convincing evidence for a cause-effect relationship. The sheer power of randomization cannot be overstated. It acts like a scientific equalizer, ensuring that the intervention and control groups are similar in all respects at baseline, distributing both known and unknown confounding factors equally. This makes it highly likely that any observed difference in outcome is solely due to the intervention, not some inherent group difference we didn't account for. Blinding further minimizes various forms of bias, including selection bias, measurement bias, and subject-related biases, really bolstering the objectivity of the findings. The design also inherently ensures a clear temporal relationship, meaning the exposure, the drug or intervention, is applied before the outcome occurs, removing any ambiguity about which came first, cause or effect. All of this combined means RCTs build high faith in their findings, generating highly credible results that often form the basis of clinical guidelines. Finally, RCTs directly provide incidence rates in both exposed and unexposed groups, allowing for the direct calculation of relative risk and measures like NNT.
That sounds almost perfect, like the ultimate scientific tool for proving efficacy. But surely there are drawbacks to such a rigorous approach. I mean, there must be a reason we don't use RCTs for absolutely every single health question out there.
You're absolutely right to ask. While incredibly powerful, RCTs definitely come with their share of disadvantages and limitations. They are incredibly costly and resource-intensive, requiring significant financial investment, personnel, and materials over often long periods. They are also often very time-consuming, particularly for outcomes with long latent periods. Think about studying cancer prevention. It can take years, even decades, to yield definitive results. A major concern involves ethical constraints. For example, it may not be ethical to withhold a potentially beneficial treatment from a control group if there's already strong preliminary evidence for its efficacy. Equipoise is lost. Similarly, you cannot ethically expose subjects to a known harmful intervention just for research purposes. This is a primary reason why we can't do RCTs for studying established risk factors like smoking or air pollution. Feasibility issues can also arise, making strict randomization or placebo control impractical in certain real-world settings, such as in some complex surgical trials or community-wide public health interventions. Loss to follow-up or attrition where subjects drop out of the study is a major concern. If the loss is substantial, say greater than 30%, and especially if it's differential between groups, more dropouts in one group for reasons related to the study, it can seriously bias the results and undermine the randomization. Lastly, because of potentially highly selective inclusion and exclusion criteria, or the somewhat artificial conditions of a trial, there can be limitations in generalizability, external validity. This means the findings might not apply as broadly to the diverse real-world population that doesn't perfectly fit the strict study criteria.
Okay, that makes sense. So if RCTs are the absolute gold standard for drugs, how do new vaccines get approved? It sounds like an even bigger, maybe more complex RCT, perhaps spread out over time, given how many people need to be involved and the huge importance of preventing disease in healthy populations.
You've hit on a crucial point about how this gold standard is adapted and, in fact, expanded for an even broader application like vaccines. For vaccines, the process is indeed a structured series of clinical trials that ultimately culminates in a large-scale RCT, but it begins much earlier and follows distinct phases. First, there's the preclinical phase. This involves extensive laboratory testing and animal studies. This is where scientists thoroughly test the vaccine candidate for safety, toxicity, and basic immunological response before it ever gets near a human. This is a critical barrier where many potential vaccines, maybe most, don't advance. Then, assuming it looks promising, we move to human trials, starting with Phase I. This involves a very small group, typically 20 to 80 healthy human volunteers. The main goal here is to establish initial safety, check for non-toxicity, and begin to find the appropriate dosage or formulation that actually elicits an immune response without major side effects. It's really about ensuring it's safe enough to proceed to larger groups. Phase 2 involves a larger group, usually maybe 100 to 200 individuals who are drawn from the target population. For instance, children if it's a pediatric vaccine, or perhaps older adults if it's designed for that demographic. Here, the aim is to assess the vaccine's biological activity, its preliminary efficacy, does it seem to work, and its safety on a slightly larger scale. You're looking for early signs that it works and continues to be safe. And then comes Phase 3. This is the actual classical RCT stage. It involves a large number of participants, often tens of thousands, and is designed to rigorously compare the new vaccine's efficacy against a placebo or sometimes an existing standard vaccine. This is the pivotal phase where the vaccine's main effectiveness in preventing the target disease is statistically proven or disproven. For preventative trials like vaccines, you often need even larger sample sizes than for therapeutic drugs because the outcome you're trying to prevent, the disease, might be relatively uncommon in the population, and you need enough power to detect a significant difference. Plus, you need to detect potentially rare side effects. It's here that the meticulous RCT steps we just outlined for Drug X are applied, but with a focus on preventing disease in initially healthy individuals. Sometimes, for broader public health interventions like, say, water fluoridation or a community-wide health education program, randomization might even happen at a group or community level, known as community intervention trials, though the assessment of the outcome still usually happens at the individual level within those communities. Finally, after the vaccine is approved based on Phase 3 data and marketed, we enter Phase 4, or post-marketing surveillance. This involves continual data collection and monitoring after the vaccine is in general use. Its purpose is to assess long-term effects, detect very rare side effects that might not have appeared in the earlier, smaller trial phases, and monitor effectiveness in the real world across diverse populations. This is crucial for ongoing safety and effectiveness monitoring.
Wow. So the Phase 3 trial for a vaccine would follow almost the exact same meticulous steps we just outlined for the diabetes drug randomization. Blinding, careful follow-up, but with that focus on preventing disease in healthy individuals, and often on a much larger scale. That really clarifies the approval process for something as vital as a vaccine, seeing how those gold standard principles are scaled and phased.
Precisely. The core principles of randomization, blinding, and rigorous follow-up remain absolutely central, but they are scaled up and adapted for a preventative rather than a curative goal, and built up over these sequential phases, building confidence step by careful step.
But what if it's just not ethical or feasible to conduct a full-blown RCT? Say you can't ethically withhold a certain treatment that's already known to be beneficial, or it's simply too impractical to randomize a large population to a specific exposure, like, I don't know, evaluating a major public health policy change across the whole city. Can we still gain valuable insights into health and disease without that gold standard?
This raises a really important practical question, and the answer is yes, absolutely. That's where non-randomized trials, also known as quasi-experimental studies, come into play. These are still active intervention studies, meaning the investigator does manipulate a variable or introduce an intervention, but they do so without strict random allocation or sometimes without a placebo control group in the traditional sense. They are employed when a full RCT is simply not feasible or ethical for various reasons. They offer a powerful alternative when the gold standard is out of reach, but you still want to evaluate an intervention.
Okay, so what types of these less than gold standard but still potentially important studies exist? How do they work?
There are a few key types. You have non-randomized concurrent trials, where subjects are divided into intervention and control groups, but the assignment isn't random. It might be based on, say, clinical condition, geographical location, physician preference, or even just pragmatic factors like the availability of a new treatment in one clinic versus another using the old standard. Then there are before and after trials, which often use historical controls. Here, you compare outcomes in a group before an intervention is introduced to outcomes in the same group after the intervention. Or sometimes you compare the post-intervention group to a historical control group from a different earlier time period before the intervention existed. And finally, there are natural experiments. These are fascinating situations where populations have somehow naturally separated themselves into exposed and unexposed groups due to some external event or policy change, basically mimicking an experimental setup without the researcher intervening directly in allocation. This allows epidemiologists to test hypotheses by observing the outcomes. John Snow's famous investigation of the London cholera epidemic in the 19th century is a classic example. He observed the natural experiment of different households getting water from different companies with varying levels of contamination.
Interesting. So what's the catch with these non-randomized approaches? If they're not the gold standard, what are their main disadvantages and limitations compared to a proper RCT?
Well, the main drawback, fundamentally, is the lack of true comparability between the groups at the start. Without randomization, there's a high potential, even a likelihood, that the intervention and control groups aren't similar at baseline in ways that could affect the outcome, ways maybe you haven't even measured. This can lead to significant selection bias because the factors that influenced why someone ended up in the intervention group versus the control group might also be related to their risk of the outcome, making it really hard to attribute any observed effect solely to the intervention itself. This also means there's a greater difficulty in ensuring all confounding variables are equally distributed between the groups, potentially leading to distorted or misleading findings. In before and after trials specifically, any observed changes might be due to other factors or concurrent events happening in the community or environment at the same time as the intervention, not just the intervention itself. Maybe diets changed or a new unrelated health program started. You can't be sure your intervention was the sole cause of the change. Ultimately, because of the absence of randomization and often weaker controls, there is significantly reduced confidence in the causal inference compared to an RCT. You just can't be as sure that the intervention caused the outcome. However, researchers can try to improve confidence by conducting rigorous baseline comparisons of the group's unknown factors and making statistical efforts to adjust for identified confounders during analysis. This can give us more confidence in the findings than, say, simple observation, but it doesn't fully replace the power of randomization.
Okay, so experimental studies, whether randomized or not, are about testing interventions, actively seeing what happens when you change something. What about the other big category, observational studies, those where we just watch what naturally unfolds without any interference from the researcher? These are probably what we hear about most often in the news, right? Like studies linking diet to heart disease or lifestyle to cancer.
That's our next big category, and you're absolutely right. They're fundamental to understanding real-world patterns and are very common. Analytical observational studies are designed to test hypotheses about cause-effect relationships by comparing groups, but, as you said, crucially, without the investigator's intervention. They're all about discerning patterns in existing data, or naturally occurring exposures and outcomes. There are three main types here that are really crucial for understanding how we learn about health risks and benefits in the real world. Case control studies, cohort studies, and cross-sectional analytics studies. Each has its unique strengths and weaknesses, making them suitable for different research questions, especially those that don't lend themselves to experimental manipulation for ethical or practical reasons.
Okay, let's start with case control studies. They sound like detective work, like you said before, piecing things together backward from a known outcome, trying to find the cause.
That's a perfect way to put it, yeah. Case control studies are indeed fundamentally retrospective studies that proceed backward in time from effect to cause. The investigator starts by identifying a group of individuals who have the disease or outcome of interest. These are your cases. Then, they carefully select and compare them to a group of similar individuals who do not have the disease. These are your controls. The crucial step, then, is to ascertain their past history of exposure to a suspected cause or risk factor. You're looking back to see if the cases were more likely to have been exposed than the controls. If the frequency of exposure is significantly higher in the cases than in the controls, it suggests an association between that exposure and the disease. The unit of study here, importantly, is the individual patient, making it very focused on individual histories.
So the key features are, you start with the outcome, the disease, then look back at the exposure history. You absolutely need that control group for comparison. And you calculate something called the odds ratio. And they're especially good for rare diseases. Why is that?
Exactly. The direction of inquiry is definitively from outcome back to exposure. The outcome must have already occurred when the study begins. The use of a control group is absolutely critical to support or refute any inference about causation. They provide the baseline comparison, the what if they hadn't been exposed scenario. While they don't directly give you incidence or prevalence rates, like how many new cases per year, they calculate the odds ratio, OR. The OR is an estimate of the relative risk, telling you the odds of exposure among cases compared to the odds of exposure among controls. And this measure, and the design itself, is particularly useful and efficient for rare diseases. Imagine trying to study a very rare cancer by following thousands of healthy people forward in time. You might wait decades and see only a handful of cases. With a case control study, you start by gathering those few existing cases, making it much more feasible. This design is also excellent for diseases with long latent periods, like many cancers or chronic conditions that take years to develop, because you can efficiently look back over decades of potential exposure history. And importantly, it allows you to examine multiple potential risk factors for a single disease simultaneously in one study. You can ask your cases and controls about diet, smoking history, occupational exposures, genetics, all at once.
That really highlights a key strength. If you're trying to figure out the cause of a rare disease, this is often your go-to method, because you don't have to wait years for new cases to appear. You start with the existing ones and work backward.
Precisely. You begin with the affected individuals, which makes it highly efficient for rare conditions. Now, to conduct one of these studies properly, you follow a detailed set of steps. First, you specify the total and actual study population, identifying the source population from which both your cases and controls will ultimately be drawn. For example, residents of a specific city, patients at a certain hospital network. Second, you specify major study variables and their scales of measurement, clearly defining your outcome variable, the disease using strict diagnostic criteria, your exposure variable, the suspected cause, and any potential confounding factors you need to measure, along with exactly how you'll measure them. For example, yes, no, level of exposure, duration. Third, you calculate the sample size needed for your cases and controls, balancing the need for statistical power to detect an association with the practicalities of finding enough eligible participants, especially for rare diseases. Fourth, you specify the selection criteria of cases. This involves having very clear diagnostic criteria for who qualifies as a case and eligibility criteria, for example, age range, time since diagnosis. You also need to identify their source, for example, a hospital's pathology registry, an outpatient clinic, population-based cancer registries, and specify your sampling method, for example, all eligible cases in a time period, a random sample. It's generally preferred, if possible, to select incident, newly occurring cases over prevalent existing cases. This helps minimize something called survivorship bias, ensuring you capture cases closer to the time of diagnosis and representing the full spectrum of the disease, not just those who happen to survive long enough to be included in a study of existing cases. Fifth, and this is a really crucial step where many studies can stumble, you specify the selection procedure of controls. Controls must, ideally, come from the same source population that gave rise to the cases. This means if your cases came from a specific hospital, your controls should ideally come from that same hospital population with different diagnoses, or from the same community the hospital serves. They must also have had a reasonable chance of being exposed to the factor of interest if they had developed the disease, i.e., they shouldn't be selected based on something related to the exposure itself. Sources for controls can be hospital-based, patients with other diagnoses thought to be unrelated to the exposure, population-based, randomly selected healthy individuals from the community, or even friends or relatives of cases. Typically, one control per case is studied, though for increased statistical precision, especially if cases are rare, you might select up to 4 or 5 controls per case. Matching controls to cases on known confounders like age, sex, or socioeconomic status is highly recommended. This means for each case, you find one or more controls who are similar on those specific factors, helping to distribute these known confounders more equally between your groups and improve comparability. Sixth, throughout the planning and execution, you need to focus on ensuring validity and reliability and preventing bias. This involves implementing specific measures, such as blinding where possible, for example, blinding the person interviewing subjects to whether they are a case or control to prevent interviewer bias, using multiple sources of information to corroborate exposure history, not just relying on memory, and perhaps making unobtrusive measurements, like checking pharmacy records instead of asking about medication use, to reduce reliance on subjective recall. Seventh, it's almost always advisable to do a pilot study on a small sample, perhaps 5-10% of your planned total sample size. This helps you pretest your questionnaires, interview techniques, recruitment methods, and data collection procedures, allowing you to identify and fix any problems before launching the full-scale study. Eighth, You conduct the study, meticulously collecting the data according to your protocol, ensuring data quality, and managing logistics. And finally, ninth, you move to the analysis of data. Here, you organize your data into that familiar 2x2 table, cases controls versus unexposed. You then calculate the odds ratio, OR, and its 95% confidence interval as your primary measure of association. The formula for the OR is simply AXD, BXC, where A is exposed cases, B is exposed controls, C is unexposed cases, and D is unexposed controls. You also perform hypothesis testing, like the chi-square test, to assess the statistical significance of your OR. And crucially, you control for confounding factors using statistical methods like stratified analysis, analyzing the association within different subgroups, smokers versus non-smokers, or multiple logistic regression analysis, which allows you to estimate the OR for the exposure while simultaneously adjusting for the influence of multiple potential confounders.
Okay, that's a really detailed process. But you mentioned potential stumbles, especially around controls, and you talked about bias before. If you're looking backward, relying heavily on people's memory or maybe old records, aren't there just a ton of ways things can go wrong or be biased? It sounds like a real minefield for potentially skewed results, maybe missing the true story or even finding associations that aren't real.
You've hit on the critical vulnerability of case control studies, and it's something researchers wrestle with constantly. They are indeed particularly prone to various forms of bias, primarily selection bias and information bias. It's their inherent challenge, and researchers have to put great effort into anticipating and mitigating these potential pitfalls. Selection bias occurs when there are systematic differences in how cases and controls are chosen for the study, leading to a comparison that isn't truly fair or representative. For instance, incidence prevalence bias, also sometimes called Neyman's bias or survivorship bias, is a big one. It arises because you're often studying existing prevalent cases rather than only new incident ones. These prevalent cases might systematically differ from those who were newly diagnosed. Perhaps very severe cases died quickly and therefore aren't available to be included in your study, or maybe milder cases recovered before they could be identified and enrolled. If the exposure you're studying is related to survival or disease severity, this can seriously distort the observed association. Another key type is inappropriate control group selection. If your controls don't truly represent the source population that gave rise to your cases in terms of their potential for exposure, then your comparison is flawed from the start. For example, using only hospital controls might be problematic if the reasons for their hospitalization are somehow linked to the exposure you're studying. Bergson's bias is a specific type where differential hospital admission rates between cases and controls based on exposure status can create a spurious association. The healthy worker effect is another, where studying employed populations might show lower disease rates simply because people who are working are generally healthier than the general population, which could bias comparisons if exposure is related to occupation. Then there's information bias, also called measurement bias or misclassification bias. This arises from systematic differences in how data about exposure or outcome is collected from cases versus controls. The most well-known and often most problematic is recall bias, sometimes called reporting bias. Cases who already have the disease might think more intensely about past exposures, trying to identify a reason for their illness. They might therefore recall past exposures more accurately or perhaps differently, maybe over-reporting suspected exposures, compared to controls who don't have the same motivation to scrutinize their past. For example, a parent whose child has a specific birth defect might more intensely search their memory for any unusual exposures during pregnancy compared to a parent whose child is healthy, potentially leading to differential reporting. Another type is observers or interviewers bias. If the investigator conducting interviews or abstracting records knows whether the subject is a case or a control, they might probe more.
Wow, okay. That's a sobering list of potential biases. Given these significant challenges, how do researchers actually try to prevent them? What practical steps can be taken to make sure the data collected in a case control study is as unbiased and accurate as possible?
It requires incredibly meticulous planning and execution. First, as we touched on, careful control selection is absolutely paramount. Controls must come from the same source population that gave rise to the cases. If you're using hospital-based controls, they should ideally have diagnoses thought to be unrelated to the exposure being studied, and their reasons for admission shouldn't be linked to the exposure. They must also have had a reasonable chance of being exposed to the factor of interest had they been a case. Sometimes, using multiple control groups, example, one hospital-based group and one population-based group, or controls with different types of diseases, can enhance validity. If you find similar associations when comparing cases to different control groups, it increases your confidence that the finding isn't just an artifact of one particular control group selection.
Okay, so getting the right comparison group or groups is absolutely foundational. That makes sense. What other practical steps can researchers take to make sure the information they collect is as unbiased as possible?
Second, matching, as mentioned, is a key strategy for dealing with known confounders. By selecting controls who are similar to cases on pertinent variables like age, sex, race, or socioeconomic status, you help to distribute these known confounding factors more equally between your groups right from the start, ensuring you're comparing apples to apples on those key characteristics. Third, where feasible, blinding can be applied, although it's often harder in case control studies than in RCTs. Observers or interviewers can and should be blinded to the case control status of subjects to reduce interviewer bias. Ideally, subjects should not know the specific study hypothesis being tested to minimize biased recall, though this is often difficult in practice, especially if the disease itself prompts rumination about causes. Fourth, objective exposure ascertainment is vital. Instead of solely relying on the subject's memory, which is prone to recall bias, researchers should strive to obtain information about past exposure from multiple, more objective sources whenever possible. This could include medical records, pharmacy records, employment records, birth certificates, or environmental monitoring data. Using unobtrusive measures, like reviewing historical pharmacy records for drug use rather than just asking, can also help reduce recall bias by providing concrete, documented evidence. Fifth, using standardized procedures is crucial. This includes using carefully designed, pre-tested questionnaires and standardized interview techniques. Ensuring interviewers are thoroughly trained, certified, and monitored maintains consistency in data collection across all participants and reduces variability introduced by the interviewers themselves. Sixth, having clear case and control definitions is essential. Diagnostic criteria for the disease and eligibility criteria for both cases and controls must be precisely defined before the study begins and applied consistently and equally to both groups. This ensures valid and reliable classification. Seventh, as mentioned earlier, using incident cases, newly occurring cases, is strongly preferred over prevalent existing cases whenever feasible. This helps minimize survivorship bias and gives a more accurate picture of the factors related to the development of the disease, rather than just survival with it. Finally, researchers should aim to consider the entire spectrum of disease, ensuring that the study includes cases representing the full range of disease severity, mild, moderate, severe, if possible. This helps avoid selecting a biased sample of cases, for example, only severe hospitalized cases that might not represent the overall relationship between exposure and disease in the population.
That's an impressive list of safeguards for this kind of backward-looking detective work. It shows how much thought goes into trying to make these studies rigorous despite the challenges. So let's sum up. What are the overall pros and cons of using this retrospective case control approach? When does it really shine?
The advantages of case control studies are quite compelling for specific situations, making them a cornerstone of epidemiology. They are generally inexpensive and quick to conduct compared to cohort studies, which often take years and vast resources. This makes them very practical for initial investigations of potential risk factors, exploring new hypotheses, or responding to urgent public health questions like disease outbreaks. They are supremely suitable for rare diseases or outcomes, as we discussed, and also for diseases with long, latent periods, like many cancers, where a prospective cohort study would require an impractically large sample size indoor and extremely long follow-up time to accumulate enough cases. They also allow you to efficiently examine multiple potential etiological factors or exposures for a single disease simultaneously within one study. You can ask your cases and controls about a wide range of potential causes: diet, smoking, genetics, occupational history, past infections, etc. And because you're starting with existing cases and selecting a comparable number of controls, they typically require a relatively manageable sample size, making them feasible even with limited resources.
Okay, those are some significant pluses, especially for efficiency in rare diseases. And the flip side, where do they fall short? Even with all those safeguards in place, what are the main limitations?
The disadvantages are primarily centered on their inherent retrospective design and the biases that can arise from it. As we noted, they cannot directly measure incidence, the rate of new cases, or prevalence, the proportion of existing cases, in the population. They only provide an estimate of the association, the odds ratio. They are, as we've discussed extensively, prone to various biases, particularly recall bias and selection biases like survivorship bias. These biases can significantly affect the validity of the findings and potentially lead to false associations, finding a link that isn't real, or missing a true association. Controlling these biases is a major methodological challenge. The backward-looking nature also creates difficulty in definitively establishing the temporal relationship. It's much harder to be absolutely certain that the exposure preceded the onset of the disease based solely on retrospective data, leading to that classic chicken or egg dilemma in some situations. They're generally not suitable for studying rare exposures because even if you have enough cases, you might struggle to find enough cases and controls who had that specific rare exposure to make a meaningful comparison. Cohort studies are better for rare exposures. And finally, they are generally limited for studying multiple outcomes from a single exposure. They typically focus on identifying risk factors for a single predefined outcome or disease. You start with the disease and look back for causes, not the other way around.
Okay, that comparison makes things clear. Now, if case control is looking backward from outcome to exposure, then cohort studies must be the opposite, right? Looking forward from exposure to outcome, following people over time to see who gets sick.
Precisely. You've nailed the fundamental difference and the directionality. Cohort studies are indeed primarily prospective, meaning forward-looking, though some can be retrospective using historical records. They proceed logically from exposure to outcome or cause to effect. They involve assembling two or more groups or cohorts of subjects who are free from the disease or outcome under study at the very beginning, at baseline. One group, the exposed cohort, has the suspected exposure or risk factor. For example, they are smokers, they work in a specific industry, they take a certain medication. The other group, the non-exposed or comparison cohort, does not have that exposure. Both groups are then followed meticulously over a specified period, which could be months, years, or even decades, to observe and compare the incidence, the rate at which the outcome, e.g. lung cancer, heart disease, develops in each group. It's like watching a scientific drama unfold in real time or fast forward using historical data.
So the key elements here are that forward direction of inquiry, starting with people who are disease-free, then meticulously following them up over time. And you can directly calculate incidence rates and something called relative risk. That sounds much more straightforward for establishing cause and effect.
That's correct. The direction of inquiry is unequivocally from exposure to outcome. Both groups are initially disease-free or confirmed free of the outcome at baseline, which confirms the exposure happened before any potential outcome developed. They involve meticulous, often long-term follow-up over time. The primary measure calculated is the relative risk, RR, also called the risk ratio. This is calculated by comparing the incidence of the outcome in the exposed group, i.e., to the incidence in the non-exposed group, I-in, so RR equals IE. It directly tells you how many times more or less likely the exposed group is to develop the outcome compared to the unexposed group. And because you're tracking the development of new cases over time, they directly provide incidence rates, which is a powerful and fundamental measure of disease occurrence in a population. Crucially, the prospective nature of the study inherently establishes the temporal association, unequivocally ensuring that the exposure occurred before the outcome, which is a huge advantage for making causal inferences.
So how do you actually conduct one of these large-scale forward-looking studies? They sound like massive undertakings, requiring huge amounts of patience and resources.
They are indeed significant undertakings, yes. The steps reflect that scale and duration. First, you specify the research question, objectives, and background significance with great precision, justifying the need for such a resource-intensive study. Second, you clearly specify variables of interest and their scales of measurement. Defining your exposure variable, often categorized, for example, smoker, non-smoker, or level of exposure, your outcome variable with clear diagnostic criteria, and any potential confounding factors you need to measure at baseline and possibly during follow-up. Third, you specify exclusion criteria for subjects you don't want in your cohorts at the start, such as those who already have the outcome disease, those with conditions that might make follow-up difficult, or those unlikely to adhere to study protocols. This helps maintain the integrity of your cohorts. Fourth, you calculate the sample size. This is critical, and particularly for rare outcomes or detecting small effect sizes, the required sample size for a cohort study can be very large, often running into the thousands or even tens or hundreds of thousands, demanding substantial recruitment efforts and funding. Fifth, you select the study cohort, your exposed group. This can involve identifying special exposure groups, like occupational cohorts, e.g. radiologists for studies on radiation exposure, or veterans exposed to Agent Orange, or defining cohorts based on participation in a health plan or residence in specific geographical boundaries, like the residents of Framingham, Massachusetts for the famous Framingham Heart Study. Sometimes the cohort is a general population sample and exposure is assessed within it. Sixth, you select the non-exposed comparison cohort. This is just as important as selecting the exposed group. The comparison group should be as similar as possible to the exposed group on all factors except the exposure itself. This comparison group can sometimes be an internal subgroup within a general population cohort, for example, comparing smokers to non-smokers within the same study population. Or you might need to assemble a separate, specially assimilated comparison cohort, e.g. workers in a different industry without the specific exposure. In some cases, if a perfect contemporary control group isn't feasible, researchers might compare the incidence in the exposed cohort against established general population incidence rates, although this is generally less ideal. The key is ensuring comparability to minimize confounding. Seventh is the long haul, follow-up and ascertainment of outcome. Both the exposed and non-exposed groups must be meticulously followed over the predetermined study period. This involves making unbiased, consistent measurements or assessments to detect the development of the outcomes of interest. This might involve periodic questionnaires, physical exams, lab tests, reviews of medical records, or checking death certificates. The validity and reliability of outcome ascertainment are paramount. Eighth, throughout that long follow-up, you must actively control for biases during follow-up. This includes potential measurement or ascertainment bias. For example, if exposed subjects are monitored more closely for the outcome than unexposed subjects. Observer bias, if investigators assessing outcomes know the exposure status. And crossover bias, where subjects might change their exposure status during the study even if someone in the non-exposed group starts smoking, or someone in the exposed group quits. And perhaps the most critical challenge during follow-up is minimizing loss to follow-up bias. If a substantial number of participants drop out, and especially if the reasons for dropping out are different between the exposed and non-exposed groups, differential attrition, it can seriously bias the results and undermine the study's validity. Researchers need robust strategies like regular contact, incentives, tracking methods to minimize losses and keep follow-up rates high, ideally well above 80%. And finally, ninth, after potentially years of data collection, you conduct the statistical analysis. You calculate the incidence of the outcome in both the exposed, i.e. and non-exposed INE groups, often expressed as cases per person, years of follow-up. You then compute the relative risk, RREEINE, and its 95% confidence interval, giving you a precise measure of the strength of the association. And very importantly, you adjust for potential confounding variables measured at baseline and sometimes updated during follow-up, using statistical techniques like stratified analysis or multivariable regression analysis, e.g. Cox proportional hazards regression, to try and isolate the true independent effect of the exposure on the outcome.
These sound incredibly powerful for understanding causes, but also, as you said, like massive undertakings that require immense patience and funding. What are the main pros and cons of cohort studies when you weigh it all up?
The advantages are very strong, particularly for establishing causality, which is why they are often considered the strongest observational study design. Cohort studies provide a much stronger design for inferring causation compared to case control or cross-sectional studies because they build the temporal relationship directly into the design. Their prospective nature, or clear timeline in retrospective cohorts, provides a clear temporal association, unequivocally establishing that the exposure occurred before the outcome developed. This is crucial for cause-effect determination. There's generally no recall bias for the primary exposure because exposure status is assessed objectively at the start of the study or from historical records before any outcome has manifested. They allow for the direct calculation of incidence rates, absolute risk, in both the exposed and unexposed groups, providing fundamental information about disease frequency. This also allows for the direct calculation of relative risk, or unattributable risk. They are particularly suitable for studying rare exposures, as you can specifically select and assemble a cohort of individuals who have that rare exposure and follow them forward. They also have the unique advantage of being able to investigate multiple potential outcomes that might arise from a single exposure. For instance, you could follow a cohort of smokers and look at their risk of developing lung cancer, heart disease, stroke, COPD, and other conditions simultaneously. They are generally not affected by survivorship bias in the same way as case control or cross-sectional studies because all participants are confirmed to be free of the outcome disease at the start of the follow-up period. And finally, they can potentially track changes in exposure status over time if data is collected periodically, offering a more dynamic view of risk.
Okay, that's a lot of significant advantages, painting a very clear picture of their strengths, especially for nailing down that cause and effect timeline. But it sounds like they are also logistically incredibly challenging, potentially draining resources and taking a very long time. What are the main downsides?
They certainly are challenging. The main disadvantages include being very expensive, requiring significant financial resources for recruiting large numbers of people, collecting data repeatedly over long periods, and maintaining contact for follow-up. They are also highly time-consuming, especially for diseases with long, latent periods between exposure and onset. Results can take many years, even decades, to emerge, which might not be feasible for urgent public health questions. They typically require a large sample size, particularly if the outcome being studied is relatively rare in the population or if the expected effect of the exposure is small. This makes them inefficient for studying rare disease outcomes. You'd need an enormous cohort to see enough events. Case control studies are much better for rare outcomes. Loss to follow-up is a major, potentially crippling problem. If a substantial proportion of subjects, often cited as 20 to 30%, are lost over the course of the study, and especially if the loss is differential between the exposed and unexposed groups, for example, sicker exposed people drop out more often, it can seriously bias the calculated incidence rates and relative risk, introducing significant uncertainty. Maintaining high follow-up rates is a constant struggle. While recall bias for the primary exposure is minimized, there's still potential for measurement bias in assessing outcomes or changes in exposure confounders over time, and observer bias if assessors aren't blinded to exposure status, though blinding is often more feasible here than in case control studies. And finally, there can still be ethical issues, particularly if you're prospectively studying a potentially harmful exposure, like an environmental toxin. While you're not assigning the exposure, you are observing its effects without intervention, which can raise ethical questions about the obligation to inform or protect participants if risks become apparent during the study.
Can you give us some iconic examples of cohort studies that really changed our understanding of health? Ones that have become absolute cornerstones of public health knowledge because of their rigorous long-term approach.
Absolutely. There are several landmark examples. The Framingham Heart Study is probably one of the most famous. Initiated way back in 1948 in Framingham, Massachusetts, it's a multi-generational prospective cohort study run by the U.S. National Heart, Lung, and Blood Institute. It has provided much of what we fundamentally know about the relationship between various risk factors like high cholesterol, high blood pressure, smoking, obesity, lack of exercise, diabetes, and the subsequent development of cardiovascular diseases like heart attacks and strokes. Its insights continue to shape medical advice and public health policy worldwide today. Another profoundly impactful cohort study was the British Doctors Study, led by Richard Dahl and Austin Bradford Hill, starting in 1951. This monumental prospective study followed tens of thousands of British male doctors for over 50 years, comparing the mortality rates of smokers versus non-smokers. It provided definitive, quantitative evidence firmly establishing the causal link between smoking and lung cancer, as well as other diseases like heart disease. This study literally changed public health policy worldwide regarding tobacco control and has undoubtedly saved countless lives. These studies really demonstrate the long-term transformative power of the cohort design when done well, despite the challenges.
Wow, those are incredible examples of long-term scientific commitment. Okay, let's look at another scenario from our sources, a different kind of study. A study found that among 300 diabetics, 180 had blindness. And among 340 non-diabetics in the same population, 140 had blindness. What kind of study is this? It sounds like it's just taking a snapshot at one point in time. Rather than following people forward or backward, it's just observing what is right now.
You've precisely identified the core characteristic. This is a cross-sectional analytic study. In this design, the researcher takes a cross-section or snapshot of a defined population at a single point in time. At that same moment, they measure both the exposure status, in this case, presence or absence of diabetes, and the outcome status, presence or absence of blindness, for each individual in the sample simultaneously. It's incredibly suitable for determining the prevalence of conditions and for seeing correlations or associations between variables within that population at that specific moment, rather than definitively establishing a direct cause and effect relationship over time. You're essentially observing prevalent cases and prevalent exposures at the same time. And to put that data you mentioned into context, here's how it would look in that standard 2x2 table, which is often used to summarize data from cross-sectional and case control studies. Blindness, present blindness, absent.
Total diabetics, 180, 20, 300, 340.
Non-diabetics, 120, 300, 20, 40. Total 300, 300, 640. Okay, so it's about seeing if the two things coexist at that moment in time, like taking a single photograph of a health issue within a population. How do you go about conducting such a study? It sounds perhaps simpler than a cohort study.
The steps are generally more streamlined compared to longitudinal designs, like cohort studies, reflecting that snapshot approach. First, you clearly define the research question and objectives. For our example, it would be something like, is there an association between the prevalence of diabetes mellitus and the prevalence of blindness in a specified adult population at a specific point in time? Second, you define the total reference population and the actual study population, emphasizing the need for the study population, from which you draw your sample, to be representative of the reference population you want to generalize your findings to. Third, you specify study variables and their scales of measurement. Defining your outcome variable, blindness may be defined as visual acuity below a certain level, measured as present-absent. Your exposure variable, diabetes perhaps defined by self-report, medical record, or blood test, measured as present-absent. And any potential confounding factors you want to measure at the same time, like age, socioeconomic status, duration of diabetes if known, presence of other comorbidities. Fourth, you calculate the sample size needed, which will depend on the expected prevalence of the exposure and outcome in the population and the magnitude of the association, odds ratio, you want to be able to detect with adequate statistical power. Fifth, you describe the sampling method used to select participants from your study population. To ensure representativeness, this should ideally be a probability sampling method like simple random sampling or stratified random sampling. Sixth, even though it's a snapshot, you still need to ensure validity and reliability and prevent bias. At the planning stage, you must thoroughly consider potential biases that can affect cross-sectional studies, like selection bias if your sample isn't representative, information bias, inaccurate measurement of exposure or outcome, and particularly survivorship bias, and design strategies to minimize them. Ensuring your measurement tools like questionnaires or diagnostic tests are valid and reliable is key. Seventh, you conduct the data collection itself, often using standardized questionnaires, interviews, or clinical examinations to gather information on exposure, outcome, and confounders from each participant at that single point in time. Using pre-designed forms, conducting a pilot study on about 10% of your sample to pretest instruments and techniques, and ensuring quality control, especially if multiple data collectors are involved, are important steps here. And finally, eighth, you move to the analysis of data. You organize your collected data into that 2x2 contingency table, as we just outlined. You then calculate the odds ratio, or often specifically called the prevalence odds ratio, in this context, to measure the strength of association between diabetes and blindness among those surveyed. You perform statistical tests, like the chi-square test, to assess the statistical significance of the association. And crucially, you control for potential confounding variables measured during the survey using methods like stratified analysis or multiple logistic regression analysis to get a more accurate estimate of the association between the primary exposure and outcome.
What are the main advantages of using the snapshot approach? It sounds like it could be very practical for certain questions, especially for getting a quick overview of how common things are and if they seem linked.
It absolutely is very practical, and it offers several distinct advantages. Cross-sectional studies are generally economical and provide quick results compared to longitudinal studies like cohort studies, making them highly suitable for many public health surveillance activities for initial explorations of potential associations, or when resources are limited. They directly estimate the prevalence of the disease or health-related condition and the exposure in the population at that specific point in time. This tells you how common the condition is right now, which is vital for health service planning and resource allocation. They can be used to investigate the association of multiple exposures with multiple outcomes simultaneously within the same study. You can ask participants about various exposures and measure various health outcomes all at once in your survey. They are generally less resource-intensive in terms of time, money, and personnel compared to cohort studies because subjects are typically examined or surveyed only once, with no need for long-term follow-up. And they are particularly useful for studying health phenomena or characteristics that are relatively stable or long-lasting, and for seeing correlations between variables among relatively healthy people in the general population, not just among hospitalized patients. They are excellent for generating initial hypotheses about potential cause-effect relationships that can then be tested with more rigorous study designs.
Okay, those are strong points for practicality and prevalence, but if it's just a snapshot, I keep coming back to that major potential problem. How do you know which came first, the exposure or the outcome? It feels like the classic chicken or egg dilemma is baked right into this design. You see them together at the same time, but you don't know the order of events.
You've identified the single most significant drawback of cross-sectional studies, and it's a critical limitation when it comes to inferring causation. The major disadvantage is precisely the difficulty in establishing temporal relationship. Because exposure and outcome are measured simultaneously, you generally cannot ascertain whether the exposure preceded the outcome, which is a fundamental requirement for establishing causality. This is indeed the classic chicken or egg dilemma. For example, in our diabetes and blindness case, did diabetes lead to blindness, or did people who are already going blind perhaps adopt lifestyle changes that increase their risk of diabetes? The cross-sectional design alone can't tell us. Other disadvantages include susceptibility to survivorship bias, Neyman's bias. The study only includes individuals who are alive and available at the time of the survey. Those who might have developed the outcome, blindness, and died before the study, or perhaps had a rapidly fatal form of the disease related to the exposure, would be missed. This can lead to inaccurate estimates of prevalence and potentially biased associations, especially for diseases with high fatality rates or short durations. There can also be recall bias, though generally considered less problematic than in case control studies, because the exposure isn't necessarily something from the distant past, but relies on current status or recent history. However, bias can still occur if reporting of exposure is influenced by knowledge of the outcome status. They are not suitable for studying rare diseases or events with short durations, because in a single snapshot of the population, you're unlikely to capture enough individuals with a rare condition or catch those fleeting events to make meaningful comparisons. They cannot measure incidence, the rate of new cases developing over time, only prevalence, the proportion of existing cases at one point in time. And finally, while they are excellent for generating hypotheses about potential cause-effect relationships and describing patterns, they generally do not provide strong evidence for confirming causation on their own due to that fundamental inability to establish temporality. They show association, not necessarily causation.
Okay, so what does this all mean? We've talked about these powerful analytical studies, the backward-looking case control, the forward-looking cohort, and a snapshot cross-sectional. How do they really stack up against each other in the grand scheme of things? And when do researchers choose one over the other in the real world? It feels like they each have a specific job to do.
That's exactly right. Each design has its unique strengths and weaknesses, making them invaluable tools for different research questions in different circumstances. They aren't really in competition in a hierarchical sense, though RCTs are taught for intervention efficacy. Rather, they complement each other in building our overall understanding of health and disease. Let's specifically compare the two main analytical observational workhorses, case control and cohort studies, as they're often considered for similar types of etiological questions, but tackle them from opposite directions. For temporality, as we've stressed, case control studies are primarily retrospective, looking backward in time from a known outcome to past exposure. Cohort studies are primarily prospective, or can be historically prospective, moving forward in time from exposure to the future development of an outcome. This directly impacts the direction of reasoning. Case control reasons from outcome back to exposure, while cohort reasons forward from exposure to outcome. Regarding measuring incidence, case control studies do not directly measure incidence rates, they simply compare existing groups on past exposure. Cohort studies, because they track the development of new events over time in initially disease-free groups, do directly measure incidence. This fundamental difference affects how they measure risk. Case control uses the odds ratio, or R, which is an estimate of the relative risk, particularly valid when the disease is rare. Cohort studies directly calculate the relative risk, which is a more direct and intuitive measure of the causal relationship between exposure and outcome risk. Thinking about scope, for studying multiple outcomes from a single exposure. Cohort studies excel here. You can follow a group with a specific exposure, like smokers, and see what multiple different diseases or health conditions might develop over time: lung cancer, heart disease, stroke, etc. Case control studies are generally not suitable for this, as they start with a single outcome. Conversely, for studying multiple exposures for a single outcome, case control studies are excellent and efficient. You start with cases of a specific disease and can investigate many potential causes or exposures simultaneously. Cohort studies are less efficient for this, as you'd need different cohorts for each exposure. In terms of bias, recall bias is a potential major problem for case control studies due to their retrospective nature and reliance on memory for past exposures. It's generally not an issue for the primary exposure assessment in cohort studies, because exposure is typically assessed objectively at the start, before the outcome occurs. However, loss to follow-up is generally not an issue for case control studies, as you're looking backward, but it's a potential and often major disadvantage for cohort studies, especially long ones, if people drop out differentially. Both designs can potentially suffer from other forms of bias like selection bias, especially control selection in case control and initial cohort selection comparability in cohort, and confounding bias, which require careful design and analysis to address. Considering practicalities, in terms of time taken, case control studies generally yield results relatively quickly, often within months or a couple of years. Cohort studies typically take much longer, often many years or even decades, to accumulate enough follow-up time and outcome events for a number of subjects. Case control usually requires a smaller sample size, making it more feasible and efficient, especially for rare conditions. Cohort studies often require a very large sample, particularly for rare outcomes, or to detect small effects, making them logistically more demanding and expensive. The overall logistic efforts and costs for case control are generally much lower, whereas cohort studies are expensive and require significant ongoing effort for follow-up. Finally, regarding suitability for rare disease exposure, case control studies are excellent for studying rare diseases or outcomes, as you can start by selecting those existing rare cases. Cohort studies are generally good for studying rare exposures because you can specifically recruit and build your cohort around people with that rare exposure, but they are generally not suitable or efficient for studying rare outcomes, as you simply won't see enough events even in a large cohort over a reasonable time frame.
That concise comparison really highlights how each of these designs has a perfect scenario where it shines. It's not that one is always better than the other observationally, but that they are suited for different tasks, making them invaluable, though distinct, tools in the epidemiologist's toolkit. They really do complement each other rather than being in direct competition for every single research question. This has been a truly deep dive into the nuts and bolts of epidemiological studies. We've talked about the gold standard randomized controlled trials for testing interventions, the backward-looking detective work of case control studies for rare diseases, the forward-looking insights of cohort studies for tracking risk over time, and the snapshot understanding provided by cross-sectional analyses. But why should you, our listener, really care about these complex methods in your daily life? How does this translate to your health choices or the news you consume about health?
That's a great question, and it's crucial to connect this back. Epidemiology isn't just some abstract academic pursuit. It has vast and direct applications in our daily lives, influencing everything from the safety regulations on foods we eat to the effectiveness of the medicines we take and the public health policies designed to keep our communities safe and healthy. For example, in healthcare management, epidemiology is crucial for making a community diagnosis. It provides the data and insights needed to understand the specific health problems facing a local community, allowing public health officials to plan targeted health programs and interventions where they're needed most. It's essential for the planning and evaluation of health services, offering accurate, quantified data to design effective programs and then assess whether they actually worked. Did that new screening program reduce mortality? Epidemiology helps answer that. And critically, it supports developing health policies. Epidemiology provides the evidence base for decisions about risks to individuals and communities, often even before the exact biological mechanism of a disease is fully understood scientifically. Think about public health campaigns urging seatbelt use, promoting smoking cessation, or warning about environmental hazards. Epidemiology often provides the initial crucial data demonstrating the risk and the potential benefit of intervention. Beyond management and policy, it's absolutely vital in understanding the disease process itself. Epidemiological studies help identify the factors that cause diseases, the etiological factors or risk factors, and they help map out the natural progression or natural history of diseases within a population if left untreated. It reveals why certain diseases occur more often in some groups than others and how they spread or develop over time. In day-to-day public health practice, epidemiology is used constantly to describe the extent of health problems, assess trends over time, is this disease increasing or decreasing, identify high-risk groups, and set priorities for public health interventions, helping decide where limited resources should be focused to achieve the greatest population health impact. And maybe most directly relevant to many listeners in clinical and preventive practice, its role is foundational. It serves as the basic science for clinical research. It's indispensable for conducting scientific medical research properly and avoiding unscientific methods or conclusions that could potentially cause harm or lead to ineffective treatments. It's how we rigorously assess the effectiveness of treatment and preventive modalities, whether that's a new drug, using RCTs, a surgical intervention, a vaccine through phased trials culminating in RCTs, or even lifestyle changes like diet or exercise programs, often using cohort or case control studies. It also helps in assessing the effectiveness and utility of diagnostic procedures, evaluating whether new screening tests or diagnostic tools are accurate, reliable, and ultimately beneficial for patients. And ultimately, the findings from epidemiological studies guide clinical decisions every day. They inform doctors' recommendations to patients based on population-level evidence about risks, benefits, and probabilities, ensuring that individual patient care is grounded in the best available scientific evidence rather than just anecdote or individual intuition.
Wow. So really, every time you hear about a new medical breakthrough, a public health campaign, warnings about risk factors, or even just a doctor's recommendation about screening or treatment, epidemiology is likely the invisible hand guiding it, providing the underlying evidence. It truly sounds like it is indispensable for understanding and practicing all specialties of medicine. That's profound, the idea that this foundational science shapes so much of our health landscape, often without us even realizing it.
It really is. And ultimately, the goal of all this meticulous study is to lead to effective action, to eliminate or reduce health problems and their consequences, and ultimately to promote the health and well-being of society as a whole. It's about leveraging the scientific method to understand health patterns and translate that understanding into tangible health benefits for populations and individuals.
What an incredible journey we've taken today. We started by defining epidemiology not just as pandemic chasing, but as the basic science of public health, tracing its roots and establishing its modern indispensable role. We then unpacked the two main categories of studies: observational, where we just watch, and experimental, where researchers intervene. We spent considerable time detailing the gold standard for interventions, the randomized controlled trial, especially for testing new drugs and vaccines. We walk through each meticulous step from defining the question and calculating sample size to the critical roles of randomization and blinding in minimizing bias, right through to follow-up and statistical analysis. We also looked at when randomization isn't possible, exploring non-randomized or quasi-experimental trials which still offer valuable insights despite their limitations.
And then we shifted our focus to those powerful analytical observational studies that help us understand real-world patterns. We delved into the retrospective detective work of case control studies, seeing how they're ideal for rare diseases, and tracing multiple potential exposures back from a single outcome, while also grappling with their inherent challenges like recall bias and the importance of careful control selection. We then explored the forward-looking insights of cohort studies, following groups from exposure to potentially multiple outcomes over long periods, highlighting their strength in establishing temporal relationships, but also their demands in terms of time, cost, and follow-up. Finally, we covered cross-sectional studies, understanding them as valuable snapshots that provide prevalence data and show correlations at a single point in time, while acknowledging the significant chicken or egg dilemma they pose when trying to infer causation. Each design, as we saw, despite its unique challenges and limitations, contributes indispensable pieces to the complex, ever-evolving puzzle of human health and disease.
So this deep dive has hopefully armed you, our listener, with so much. The next time you come across a headline shouting about a new health study or a medical finding, you'll be equipped with the knowledge to ask deeper, more critical questions. Was it an observational or an experimental study? If observational, was it case control, cohort, or cross-sectional? What were its inherent limitations just based on that design choice? Were they able to blind participants or assessors to reduce bias? You'll be much better able to critically evaluate the evidence behind the claims you encounter every day.
And remember, understanding how this knowledge is created, the methods behind the headlines, is often just as important as the knowledge itself. It empowers you to engage in critical thinking, to question assumptions, to look for potential biases, and ultimately to make more informed decisions about your own health and how you interpret health information in a world that's absolutely brimming with it, not all of it reliable. It gives you the tools to distinguish genuine scientific insights from mere correlation, preliminary findings, or sometimes just hopeful claims.
So here's a final thought to ponder. Consider how understanding these different study designs, the strengths and weaknesses of RCTs versus cohort versus case control, might fundamentally change the way you interpret health advice in your daily life. What new, insightful questions might you start asking about the evidence behind the next recommendation you receive or the next health story you read? That's all for this deep dive. Thank you so much for joining us.